Hello, and welcome to Breast Cancer Conversations, a podcast brought to you by survivingbreastcancer.org. I'm Laura Carfang, breast cancer survivor and founder of survivingbreastcancer.org, a nonprofit organization providing community, education, and resources to empower those diagnosed with breast cancer and their caregivers from day one and beyond. Hello, my friends. I am so excited for yet another amazing episode today. Today's conversation is one I've been looking forward to sharing for a while because it lives at the intersection of science, survivorship, and the decisions that stay with us long after treatment ends. We talk a lot about breast cancer as patients, but what happens when the person treating breast cancer becomes the patient herself? And what happens when cancer shows up again, not as a recurrence, but as a new diagnosis? My guest today is Dr. Peled, a board-certified breast and plastic surgeon who has dedicated her career to caring for people with breast cancer, and who has also navigated an early-stage diagnosis, followed years later by a new primary, DCIS. In this episode, we talk honestly about what DCIS is and why stage 0 can be so confusing, the emotional weight of making surgical decisions, and how advances in oncoplastic and sensation-preserving mastectomies are changing what survivorship can look like. This conversation is not just about the data and the science, but also about identity, autonomy, and trusting yourself when there are multiple right choices. Welcome to the conversation. Dr. Peled, you had an early stage diagnosis and then had a reoccurrence also of an early stage diagnosis. And in that time, I'm also amazed because I'm a almost 9-year survivor myself from my diagnosis, from my early stage diagnosis. And the science has changed like incredibly. I feel like such an old timer that I was on medications that aren't even part of the regimen anymore. I had a full axillary node dissection and I'm dealing with lymphedema. And now people are getting all of these lymph node bypass surgeries and totally mitigating the risk for lymphedema. And all of this great stuff is happening. You had a very similar experience with the type of surgery that you underwent. So we're going to talk a little bit about that. And the dual hat that you wear being a breast surgeon and then also being diagnosed with breast cancer.
Thank you so much. Really excited. And honestly, all of your assumptions are very spot on. And I'm really excited to get into it with you. And I love your perspective on how incredible it is that things evolve. And I also, both as a patient and as a provider, love that piece of breast cancer care. So I'm really excited to talk about that too.
Okay, so first, formal introductions. Tell me a little bit about yourself, your background, your medical training. I believe you did some medical work here at Harvard and Boston as well. Is that
Yes.
right?
You were correct. Yeah, I'm originally from the East Coast and went to college in Western Massachusetts and then went to medical school at Harvard. I love Boston. My sister still is there actually as a breast radiation oncologist. It's what we do in our family. My parents are also my dad's a breast medical oncologist and my mom is a breast radiation oncologist. So it's literally our family business is taking care of breast cancer.
You literally sit around the table and you can do your case reviews. You're the board.
We're our very own tumor board. And I actually lean on my family a lot for these things. But so I met my husband in Boston. He is a plastic surgeon. And we met when I was doing a research fellowship during medical school and actually had both independently fallen in love with California. So we joke, no one's family can blame the other one for moving us across the country from them. But I matched at UCSF in San Francisco for my plastic surgery residency. And during that time, I actually did a couple years of combination breast cancer and breast plastic surgery research. So typically in this country, if you become a breast oncologic or a breast cancer surgeon, you do general surgery training and then become a breast cancer surgeon. And if you do breast reconstruction, you do a plastic surgery residency and then become a breast plastic surgeon. So my training is a little bit unique here in this country, although it's true in many other parts of the world because I'm dual trained. So after my plastic surgery residency, my mentor mentioned how much I love taking care of people with breast cancer. So I did a breast oncologic surgery fellowship afterward. So when I started my practice in 2015 here in San Francisco, I started out doing the full spectrum. So I do lumpectomies, mastectomies, lymph node surgery, but I also do all different kinds of breast reconstruction as well. So that's a really nice combination.
So beneficial because, if you're going in and removing cancer on one end, you know exactly what you're getting into to do the reconstruction thereafter.
You're exactly correct. It does really, and I think it's, they're amazing plastic surgeon breast surgery teams that I know and that I work with and love. And so it's not that one way is better or the other, but I do think for patients, it's really overwhelming at the beginning. You have so many appointments and so many doctors to meet with. And I like to think that at least it saves them some set of appointments to be able to come in and get the full spectrum of lumpectomy and mastectomy reconstruction options from the beginning, which I love.
Is this oncoplastic surgery? Okay. So I was very fortunate to also have an oncoplastic surgeon for my surgery.
Lucky
And
you.
they are, I don't know, again, as I feel like more of a veteran here, being 9 years out, but has the field grown? Because at the time, I feel like it was like literally you can count that in the United States, like on your hands. There was like a very small population of people who were trained in both of these aspects as you described.
Yeah, it's definitely growing for sure, both in terms of people who are fully dual trained like I am, but also, which is so great, is a lot of general surgeons who do breast surgery never learn to do things like hide scars for lumpectomies or close up the space at the time of lumpectomy so people didn't have a visual reminder, a divot dent. And so I do a lot of teaching, which I love, of teaching breast surgeons how to be able to close spaces from lumpectomies to work with a plastic surgeon for that reconstruction. So that is a great evolution in our field for sure.
Amazing. And it's getting so much better. You're absolutely right. And talking to women now, like my scars, like, I don't know, when I was going through radiation, they were like, oh, you have to like moisturize a lot because you're going through radiation therapy. And my radiation was only on one side, but I was like, I'm moisturizing everywhere. And it made such a difference, how my scars healed. And, and I know there's a lot of great cosmetic tattoo artists out there as well that can really help with scarring and kind of camouflaging the scars as well. So yeah, there's so many options these days.
Well, I love that you knew that because, like you said, I think there's a lot more of an emphasis now on what it really takes to recover. And again, one of my favorite things about being a breast and plastic surgeon now is that we treat breast cancer so well in most cases that now we get to talk about, the more fun things, if you will, but I really think about like how is recovery going to go well in prehab and how we get through physical therapy afterwards and scar management. And again, I think this is in my mind such a gift that we're able to have these kind of conversations because from a cancer standpoint, we're treating people so much better than we used to.
Absolutely. Fantastic background, great training, lots of schooling and training and residencies I can imagine. So thank you for all of that time and effort you put into this to make our lives better. But take me back then to when you found out you were first diagnosed with breast cancer.
Yeah, I mean, all of us, too, like it is so crazy to get diagnosed with breast cancer no matter what your story was. But I think for me particularly, I had started my practice. I was about 2 years into my breast reconstruction practice, and I felt a breast lump. I was 37, triathlete, vegetarian, no family history of breast cancer, like thought I was just, so healthy, doing so well, and then felt this breast lump and did what I tell my patients to do, which is basically if something doesn't go away after a week or two, like you have to get it checked out. Really grateful I did because I wasn't getting screened yet. I was too young to get screened and was so shocked beyond belief when the pathologist called me the next day to tell me that my biopsy had come back as invasive breast cancer. So I feel, again, very grateful to have gotten on it early. And so went through all my imaging and workup and had what looked like stage 1 breast cancer. So again, very grateful to have it early stage. And at that time, back in early 2018, I had a lumpectomy. I had oncoplastic breast reconstruction and a sentinel node biopsy and confirmed stage 1. I had testings that I didn't need chemo at the time, which also felt like a gift, and then went on to radiation and hormone blocking therapy with tamoxifen. So that was early 2018. I did still on my tamoxifen, doing my screening, MRIs, mammograms every 6 months, feeling really great and fine, and was really floored last year when one of my mammograms came back with new calcifications. And again, like grateful for screening, grateful for being on top of it. But at the time, they did a biopsy of it, and it ended up actually being, even though it was the same side, it was actually a new cancer. So my first one was hormone receptor positive, HER2 negative, invasive. And this was hormone receptor negative, a stage 0 DCIS in a different part of the breast. So really, truly like a new cancer, which with negative genetic testing is unusual, but not unheard of. So at that point, just because I'd already gone through a lumpectomy and radiation, and this was not sensitive to hormones, I really needed to do something different. And so at that time, decided that I would have a double mastectomy.
So, wow, so much to unpack there. Thank you for rehashing your story, which I know is always traumatic, but we say it like, my birthday was yesterday and my anniversary is this, and I have 3 kids and 2 dogs. And, it's just like these things stick out so vividly. So first diagnosis, was it through just like showering, or did you just do self breast exams, or like when you noticed a lump, did you immediately, given your knowledge and background in breast health, think it was breast cancer, or kind of mental state? Like what was going on the first time?
Yeah, so I found it for a self-breast exam, but I really truly just assumed it was gonna be a cyst. Like, it was just gonna be a cyst because I, again, had no reason to think that I was gonna be getting breast cancer at 37. So, yeah, was happy I got it worked out, but, like, truly, I remember the moment I was scrubbing into surgery to do a double mastectomy and someone with cancer, and the pathologist called me, and I just knew, like, they wouldn't call me if this were a cyst, and I remember, like, right? Like, you don't want your pathologist you work with to be calling you. And I mean, literally the moment I picked up, I just, like you said, you're just instantly taken back to that moment of just being so floored that that's what it was at the
My
time.
other question is, since you work in the medical setting, did you get your biopsy with your colleagues in your hospital?
Yes. So great question. So I did. I help run our breast cancer program here at my hospital. And so I really love my radiologists and I love the people I work with. I will say ultimately, and we can kind of talk about surgery options if you want, but I ultimately decided to go out of system for the rest of my treatment. It just, I run our tumor board every week and it just felt like a lot to see everyone. I do have my medical oncologist here whom I love, but she is the best and sees me basically virtually and orders all my testing for me and kind of like lets me run the ship. But for everything else, surgery and radiation, it felt like too much to be taken care of by people I
And
see
that's
every
what I
day.
wanted to ask too. Just when we think about, got diagnosed with breast cancer, how do I tell my employer? What's the sensitivity around that? Who do I want in my, work environment to know? And then given the complexity of, this is your work, how do you navigate that and kind of what was going on? So I appreciate you addressing that. An interesting story on someone else I was interviewing on the podcast, also in the medical field. I think she went out of system and ended up getting a biopsy from one of her residents and students that she trained a few years earlier, who was at that hospital. So like, even though you go and try and do your best to be like, you know what, I want to remove myself, you never know how the stars align. And for her, it ended up being like a really great experience because it took the best care of her. We're so like emotionally supportive of everything that she was going through too. But it's kind of these stories of like, okay, how do I navigate and who do I want to know my whole history and read my chart and all of these things around HIPAA, right?
Oh, completely. And I mean, we'll get to it in a little bit, I'm sure. But my most recent diagnosis, I was really open with my patients because I had to take time off to heal from surgery. And so I actually had my patients tell other people I work with, like, oh, Dr. Pelled's out because of her cancer diagnosis. And then they knew but didn't want to ask me. And so it's like this whole thing of, again, you kind of decide how open you're going to be out in the world, but then you also have consequences of that. So it is definitely it's a dynamic. And I think one of the things I've learned so much is people have very different levels, right? Of like what feels comfortable to them and what helps them get through it. And I have people who don't even tell their partners, not their work partners, but their home partners, right? I have people who don't even tell their adult kids and they make those choices. And then other people, again, who from the moment they get biopsy, they're sharing. And I think it's so important for all of us to, especially like who are taking care of patients with breast cancer, to try to meet people where they are because the level of trauma, again, it somehow was a lot easier with my recurrence, even though I was surprised because I'd been through it. But I think, again, everyone is so different on how much trauma it brings and what makes sense for them.
And so, fast forwarding to your most recent diagnosis, I think this is such a salient point because you were on tamoxifen, which in theory is supposed to, block all of the estrogen and hormonal blockers for the ER positive breast cancer. But then, of course, it will do absolutely nothing for triple negative. And so, it's also the risk factor, right? Of like, if you're within your first like 5 years, 3 years, 5 years, different time frames for survivorship, like the risk for recurrence also plays a factor in, kind of that survivorship timeline. So empathize in the sense that like for those of us who've had lumpectomies and are still going in for mammograms are like, gosh, this is where it started. This is all where it started. And now I'm going back. And so when you found these kind of calcifications and were going through that piece, what was going through your mind? Were you thinking, oh gosh, it's back? Or were you like, oh, calcifications, this is nothing. I was thinking a cyst again all over again.
No, I mean, I kind of knew, like, again, just sort of like the radiologist showed me in the area and they called it low suspicion. But I have to say, I have a good friend of mine who got diagnosed at 40 and she had suspicious calcifications. They told her almost probably nothing. Then it came back as DCIS. No problem, DCIS, stage 0. Then she had a double mastectomy. She had unexpected invasive cancer, and it was involved in her nodes. Oh, even she's doing beautifully. We're about to celebrate her 10-year cancer anniversary with yoga class in 2 weeks. But she and I always talk about when you end up on the percentage of, right, like getting cancer under 40, having something be something where they tell you it's low risk. Like once you end up in that kind of unexpected, the numbers aren't supposed to work the way they do category, I have to say, like even when they told me my calcifications were low suspicion, I was like, they might not be. Like I had a pretty good sense. I was kind of ready. I do think the hormone receptor negative part and this not being a recurrence really surprised me because we all kind of know there is a chance of a recurrence, both with lumpectomy and mastectomy. But my sister, the one who's a breast radiation oncologist, we talked about it and she was like, well, your tamoxifen has done its job, and that's true, right? Like here I am at this point, 8 years out, like from that part of it, no signs. I get tumor marker testing of my like circulating tumor DNA every 6 months to make sure my invasive cancer hasn't come back. And it's been negative and everything's been good. So I kind of try to use my medical brain to remind myself, like everything I did actually worked for my first cancer. This is just the bad luck that is my breast doing crazy things to have a different one. But again, at least it was caught really early, so I could do something great about it.
And you bring up a really good point with just regards to terminology, the recurrence versus a second diagnosis. I think that is something to like really linger on as well, because we think when the cancer comes back, it's a recurrence. But as you're describing it, given its biological characteristics, it's really like a second primary that you're managing.
Exactly. And I mean, it's technically treated as a recurrence to some degree in terms of surgical options. So it was kind of an interesting one to be talking about. And from, patient perspective and sharing, it's hard to have those nuances. Obviously, you're in the space and having these conversations in a nuanced way all the time. But I think all of this can be really tricky. And one of the things I decided when I first got diagnosed in 2017 was for me, I have all my family does this. I have access to the best care, my colleagues and friends. I got biopsy results within, 12 hours. I got an MRI the next day. I get all this stuff, right? That I'm so fortunate and so lucky to have. But one of my goals is really to try to figure out like how everyone can get a sense of what their options are and how do you do research and how do you understand your pathology report and these things that, again, I am so fortunate to get to do because this is what I do every day. But most people don't have that. And so how to help with that accessibility.
You're actually one of those people that can look at your portal, read the results, and know what they mean versus the rest of us totally freak out.
Oh, I know. Although with AI nowadays, I had someone come in the other day and the stuff that she'd pulled out of her pathology report, I had to think about it because AI had given her this, very detailed, and I was like, I don't even think about that part of your pathology report, but now I had to because AI had suggested something. We're all kind of learning together how we make sense of these things, but I think having more information out there is never going to be a bad thing to help people with decision making.
So to take a deeper dive into DCIS, this I find to be a very tricky diagnosis because on one hand, it's categorized as stage 0, which I don't know why they call it stage 0. Misnomer right there, right? You're like, oh, 0 should be nothing, but it's something. And then at the same time too, I feel like, how do you navigate that? I would say maybe a twofold question. How do you navigate that with your patients? And then how do you navigate your surgery options, even like with yourself as you were kind of navigating, okay, I have DCIS and what, I don't know. I feel like it's less black and white. I feel like sometimes when you're diagnosed with something a little bit more advanced, it's like you're not really given options. You're like, this is the protocol and this is what we're doing.
100% agree with you. My sister and my mom, again, from a radiation standpoint, we always talk about how DCIS is actually some of the most complicated conversations we have, both surgery and radiation, for this exact reason. I think it's also, again, my situation was very unique with this new primary and it being hormone receptor negative. But the concern is that some DCIS never becomes anything but stage 0 DCIS. And some actually comes back or can evolve into invasive cancer. And certainly having triple negative invasive cancer would have involved a lot more for me in terms of having chemo and things like that. So I thought it was interesting having gone through this myself. You do fall in like a little bit of a gray zone with DCIS. Like medical oncologists aren't really the people to take care of you. They're focusing, primarily on trying to prevent people from getting cancer in the rest of their body, also locally, but primarily the rest of the body. And then for me, from a radiation and surgery standpoint, it was kind of, well, you've already had a lumpectomy and radiation. You have no options except a mastectomy. So it was definitely, yeah, I learned a lot about how unclear to some degree some of that is and not really having a good home the way some other things do. I think, one of the things that I found myself going through this in the first place was really how important it is to get a sense of what people are up for and what their goals and priorities were. And I say this because for me, when I got diagnosed at 37, most people would have a double mastectomy. Like that was just, you got diagnosed young, your breast cancer, your breast cells are doing crazy things, like you have a double mastectomy. And it was really interesting kind of going through that process myself and realizing I really, really, really didn't want one. I was worried about complications. I was worried about more involved surgery. I had 3 kids under the age of 5, 6 at that time. I had this new practice and I really didn't want to have any of those things. And I think the other big thing that I really didn't
right now.
I did not have time for it. But the other thing I realized is my same friend, the one who was now celebrating 10 years, she had a mastectomy, a double mastectomy. And she said, I put my sports bra on and I don't know it's on. And I just remember that at the time thinking at 37 as an athlete and being so active and my job being so physical, like how was I possibly going to have like this entire part of my body be fully numb for the rest of my life? And so at the time, choosing a lumpectomy felt like such a good choice and the right choice for me. But it was also a great opportunity to figure out this technique that my husband and I have helped develop to allow people to preserve sensation. So again, I look back on that time, I'm like, wow, I really knew what I did and didn't want and putting my priorities first. Like I would still pick that again, even with having to have the second diagnosis. And I think as providers and as caregivers and people supporting and people in our community, as much as we can do to let people figure out when they have choices, like with DCIS, what their real goals are, I think that allows us to provide better care and better options.
So did you end up having a single mastectomy or a double and then reconstruction afterwards?
I did. So I had my lumpectomy and my oncoplastic surgery back then. I had radiation and I honestly healed overall incredibly well. I feel very, very fortunate for my first team of surgeons and how well I healed. But this time around, I really thought through, would I just have a single? Certainly with negative genetic testing, a double mastectomy wasn't really necessary. I never have, knock on wood, had anything bad on the other side, but it just felt like at this point, like having 2 separate cancers by 44, I was like, I think it's time to just, be able to be proactive about the other side as well. So I was glad I did it. And certainly with sensation preservation as an option now, it really changed the whole landscape for me and changes how I talk to my patients about what their options are.
So did you end up going with implants then or doing deep flap?
I had a double nipple sparing mastectomy with nerve reconstruction and over the muscle implant reconstruction at the same time, all in one surgery.
Amazing. Okay, perfect. So that's the stage for the surgery. Again, as we're talking, and this has come up a couple times already in our conversation, I lead a lot of support groups, the work that I do at survivingbreastcancer.org. We hear these stories. No one ever tells you you're going to lose sensation. No one never tells you all of these other things. We're all just concerned about getting the cancer out and then having some sort of, aesthetic, symmetry. Then I remember that being just such a pain point's not the right word, like an emotional loss, I would say, as we think about our identity, our femininity, what it means to be a woman, to be a female, to be sensual and sexual, etc., and to lose this sensation that no one was actually talking about because we're talking to our oncologists or our surgeons, and it's all business basically. And when you think about side effects, you're kind of thinking of like how the skin is healing, not necessarily these other side effects that could really, I would say, impact the whole person outside of just the practical, if you will. So tell me a little bit then how you came to discover, invent, create this technology.
For sure. And I think your points are so spot on, which is that really, like you said, yes, there's a lot of focus on just like, what is the operation to get the cancer out? Then we've evolved now. So we have better reconstructive options and we're trying to actually have people like look like themselves again. But the functional piece really often, isn't taken into account, and it's sensation, but it's other things too. Like I always think about flaps are a great option. For me, I didn't really have enough tissue for it. I'm super active. It just wasn't something I could do or go through. I think flaps are a really good choice for a lot of people, but it's so important we talk about like what the impact might be, not for everyone, but might be on your trunk and your torso, and really get a sense of like what is the potential downside of it. Similarly with implants, you're going to probably have to have surgery again. Implants don't last forever. We like to think nowadays 20, 25 years out of them, if not longer. But if you're 30 something and you put in implants, you're probably going to have another surgery. So I think, again, we're doing a better job now really trying to help people with that. And so when it comes to sensation, like you said, so many people don't know they're going to lose sensation. And while I firmly believe that sexual sensation and nipple sensation is incredibly important, it's actually so much more than that. So it's people who will tell stories of they put a heating pad on their body and burn through their skin and now have an exposed implant because they couldn't feel it when it was on, clothes falling off at the gym because you don't know. And then there's also the component of chronic pain. So when you injure nerves, you don't just cause numbness, you can also cause balls of scar tissue. So I think, for me and for my husband, who's a peripheral nerve surgeon, it just made so much sense to try to do something better than that kind of, okay, you're going to be numb. Maybe you'll get a little sensation back if you're lucky. 60% of the time, you're going to have some chronic pain. And this is kind of just what you have with a mastectomy. We literally, talking over the dinner table, talked about if you can reconstruct nerves in other part of the body, if you can use these nerve grafts. So again, very cool technology advances where you actually take cadaver nerves and take out the cells of them and then use them as almost a conduit for your own nerve to grow through over time. So now we use them in the arms, the legs, other parts of the body. And so now we can use them in breast surgery as well. So that was kind of the idea, was what if we look for nerves, we try not to injure the ones that can be safely saved right under the skin with a mastectomy instead of just cutting through them and leaving balls of scar tissue and pain and numbness. What if we can keep some of those and then reconstruct the ones that we can't? So we had, I had my lumpectomy in January 2018, and we did our first what we call sensation-preserving mastectomy in February 2018 and kind of haven't looked back. So at this point, I think we've done over about 13 or 1,400 of these surgeries, and it is just the coolest thing to see people talk about how they get to feel like themselves again. Their breasts play a role in their sexual intimacy and relationships with their partners. They really feel like themselves again. And it's not perfect. A lot of people don't get back all their sensation, go back to normal, but most people feel most everything to some degree. And that's been really, really exciting to see.
That's amazing. I feel like I'm missing a middle part of this story though. So do you just I'm going to go into the operating room now and perform this? Were there trials? Were there did you how? I feel like I'm missing something, but I'm very excited about it.
No, I mean, this is my very unique story of being married to a peripheral nerve surgeon where literally we can talk today and are like, hey, you reconstruct nerves and look for nerves in other part of the body all the time. I do mastectomies and reconstruction all the time. How can we bring this together? Honestly, for decades now, people have been doing nerve reconstruction with flaps. So if you do a deep flap from your stomach, you can actually take nerves up and connect them to the chest. So this concept of doing nerve reconstruction in the breast, that in of itself wasn't a new idea. I think the real new idea was sort of, you have this team approach, you're going to find these nerves, and during any kind of reconstruction in real time, maybe with implants, maybe with flat closure, maybe with flaps, you're going to actually reconstruct these nerves. So truly, my husband and I kind of came up with it as a proof of concept, we could do it. And we found a patient who sensation was really important to her, basically having her prophylactic mastectomy is the only thing she wanted to get out of it, truly, was being able to keep nipple sensation and skin sensation. So it was kind of a perfect person to try and see what we could do. And there's no real downside to it. It doesn't make your mastectomy worse in terms of oncologic outcomes. It adds a little bit of extra time, added more at the time with the learning curve, but it was someone who was really invested. And so when technically we found we were certainly able to do it, we've been collecting prospectively people on, it's a trial, but at this point, this is so widely accepted. We've taught people across the world, so it's not really truly a trial, but that was kind of the idea, was let's track people's sensation before and after and see how it comes back and how that's different from the standard of what we know in the literature from non-sensation preserving mastectomies.
Amazing. Well, congratulations. I love from bench to bedside, with table to operating room, dinner table to operating. I love the duo with the husband and just your background. I'm curious, we're always talking about conversations you need to have with your surgeons, questions to ask your doctors, who's part of your care team. You said that your husband was a nerve surgeon. What was the exact title?
Yeah, peripheral nerve surgeon.
Nerve surgeon. So is this someone that most hospitals have, that they would come in and partner with your surgeon on this? Or tell me a little bit more about the logistics of how someone would go about advocating for this.
Yes, I love that question. So the first piece I tell everyone is when you meet with a breast surgeon, just ask them straight up, what is the chance that you're going to be able to keep any meaningful sensation in your breast after your mastectomy? We've been training, and the group that makes the nerve grafts and others have been training people across the country for years now. And so many surgeons in many places will be able to look at you and say, yes, we do this technique where we try to keep nerves. And so if you have someone who's comfortable with that conversation, you'll know instantly, well, they're up for it. Many people, unfortunately, are going to say, like, nope, you're just going to be numb after surgery. And again, not everyone gets the luxury and the choice of second or third opinions, even though I love them and everyone should get them for everything. But that is potentially what you hear. So if you have someone who is up for it on the breast surgery side, most of them will work with a plastic surgeon who is able to do your nerve reconstruction. Now, not all plastic surgeons will have had training in it, but plastic surgeons, many of them who do microsurgery, like for a flap reconstruction, it's very easy for them to put nerves together. It's easier than putting blood vessels together that you need for the microsurgical reconstruction. And then there are other plastic surgeons who've learned how to do it over time, even though they aren't technically nerve surgeons. So for most people, you don't need a third surgeon. You would have your breast surgeon and your breast plastic surgeon, and the two of them would work together.
So I feel like we need like a new term for you to go beyond just oncoplastic, but now you're doing the surgery, the reconstruction, and now like the nerve preserving. So whatever that term is, we heard it here first on Breast Cancer Conversations. I love that.
I love it, Laura. Thanks.
One thing that we didn't talk about, not feeling blame for having a recurrence. You touched upon this a little bit when you said, given your lifestyle and what was important to you and what your values were at the time of your initial diagnosis, having the lumpectomy was the best choice for you. And so I think it's easier said than done, but how do we make sure that, oh gosh, should I have had that mastectomy then, and this would have never happened? Or kind of that like little like annoying person in our brains that kind of like talk us up all the anxiety.
Yeah. So, I mean, it's such a good question. And I think even taking a step back from this, like there's so much blame in a breast cancer diagnosis in general, right? And everyone wonders like, what could I have done? Should I have drank less in my 20s? Should I have exercised more? Should I have had kids earlier? Should I, have kids at all? I mean, it's so complicated. And so I think what all of us can do is kind of try, and I do this very much with myself in this process, is try to ground ourselves in data. Like it's the best that we can do. 1 in 8, and probably more than that at this point, honestly, women get to breast cancer. Like those are just numbers, it's math. And unfortunately, many of us who, didn't do anything to contribute to your breast cancer are going to get breast cancer. So I feel it's the same when you're thinking about recurrences. And as hard as it is for people to wrap their brains around this, your survival from breast cancer is exactly the same if you have a lumpectomy or a mastectomy. Like it just is. That's just science. It's just data. And so for me, I think about like, okay, was it a lot psychologically to have gone through a second diagnosis? Sure. But if I'd had a double mastectomy in the first place, I would be totally numb now and I would be living with that every day. And now instead, I got this sensation preserving mastectomy thanks to technology advances. And I already feel like I'm having a lot of my sensation come back 5 months out. So I think it really is something we all kind of have to try to remind ourselves, like there's nothing perfect, sadly, with cancer. People have double mastectomies and still get cancer coming back. And it's just unfortunately the nature of it. And so my thought is like, what are the things that we can do that we do no matter, right? Like I exercise every single day, non-negotiable, no matter where I am, no matter where I travel, because there's really good data on exercise preventing recurrence. And so I think, again, alcohol is another good one, right? I do drink sometimes. There are no studies that say if you have, 2 to 3 drinks a week, you're dramatically increasing your risk of breast cancer. And that's a choice that I make. And other people will quit drinking altogether. And so again, you kind of figure out where can you pull some levers to do everything you can, but also allow for the fact that unfortunately cancer just does what it's going to do. Yeah.
I agree. And your story is very similar to mine in the sense I was diagnosed under 40. I was a vegan. I was a vegetarian initially, became vegan, was very active and got no family history, no predisposition, genetics. And you're like, how the hell did this happen?
Exactly.
And I opted for the lumpectomy after going through the ups and downs of like, one day it was, I wanted a double mastectomy. I'm going flat. I need a lumpectomy. Like I was all over the board.
Yeah.
My poor husband had to deal with all of that. But, similar to you, for me, it was really important to get back to yoga. Yoga was like my thing. And to be able to do like the chaturangas and the push-ups and the inversions and have that upper body strength was like, that was the decision maker for me. Like, when can I get back to my yoga practice? And I also was not at the time eligible for a deep flap surgery. And I don't know if they still do these surgeries, but they were looking at taking the muscle and from behind my shoulder, like kind of in that, I forget what the tram flap area. And I was like, absolutely not. I will not be able to do push-ups, pull-ups, like any of my upper body things. Like it totally freaked me out. So, I think this is just really important. And I tell people in our community all the time, when I can look at myself in the mirror and just be 100% confident with my decision for me, not my mother's, not my husband's, not my friends, because everyone has an opinion. I know I made the right choice. And if it comes back, it comes back. If it doesn't, it doesn't. But, I am very happy with the decisions that we make at the time, with the information that we have at that time.
That is so key, Laura. What you just said is so key, because the reality is like we get new data and things change, and you're working with the situation you are in the rest of your life, right? We're so much more than just cancer patients. Like we have everything else going on around us. And I love that. We're just doing the best we can with what we have at that moment. I think that is like in of itself is such a huge thing to leave people with. So I really appreciate that.
Well, Dr. Peled, how can our listeners find you, follow you? Are you on social? Anything else like you want to leave them with? This was such a fun conversation. I definitely want to have you back.
Thank you. I feel the same. I'm like, we could just do this all day. There's so many things we could talk about. So I love Instagram is definitely my platform of choice. So it's Dr. Ann Peled. I love questions. I also love suggestions for topics. So it's so fun for me to hear what things people would love for me to address and to talk about. And I think, really to kind of leave someone, one of the big things I always try to tell people is like, you are the only person who wakes up every day in your body. And so I think similar to what you just said, it can be very hard for people sometimes to feel like they can advocate for themselves, to get that second or third opinion, to decide that they're going to pick the lumpectomy, even when, everyone's telling them you're 37, you should have a double mastectomy. Like it is so important. You are the only one, and it doesn't matter. No one's feelings get hurt. If I have a patient who sees me and goes somewhere else, like that is great for them if they found someone that feels like the right choice. So I think just reminding everyone, like, it's only you. It doesn't matter what any of the rest of us think is so important.
Thank you. Words of wisdom. Thank you for sharing your story, your perspective, your patient experience, your medical experience. I mean, this was the best of all worlds. So thank you for joining us today, and we will definitely be in touch.
Thanks, Laura. Such a pleasure. Really appreciate it.
And thank you, everyone, for listening to our show. I would like to acknowledge that all of the information on our podcast is from personal experiences and is not a substitute for professional medical advice. You should always contact your medical care team. If you are looking for specific topics or would like to be a guest on our show, please feel free to reach out. My email is laura@survivingbreastcancer.org. Our show is made possible by our nonprofit, survivingbreastcancer.org, and by our incredible donors like yourself. You can hop on over to survivingbreastcancer.org to sign up for our mailing list, make a donation, and explore the 400 plus programs we offer each year at survivingbreastcancer.org/events. Until next time, keep on thriving.